Thanks to everyone for joining our Q&A session today. It's a bit of an early start for us in the UK today, 5 a.m. for us, but we have Dr. Martin Weltman with us from Australia today. And if I remember right, Martin, we're 2 o'clock with you in the afternoon?
Correct, yes.
Great. So I appreciate that some people will be watching us on catch up today, but it's also really good for us to do some lives that are at good times for our patients in the other countries as well. So thank you so much for taking the time to join us. We really appreciate it.
Always a pleasure.
I'd just like to mention before we start, just to remember that these Q&As don't take the place of a consultation with your own clinician, and these sessions were aiming to provide general medical information and not medical advice. Also, please remember that Facebook is a public forum, and you can also join us with the link provided in the room in the room privately here with the doctor and I. And if you've got any questions, you can pop them in the chat for us. But in the meantime, we'll get started with the questions that have been sent in. So our first question today, Martin, is tingling in the feet, hands and arms and legs a symptom of PBC?
Not a classic symptom by any means. I don't think so. Tingling in the fingers and the hands and feet most often suggests, it may not be, but it's suggestive of a peripheral neuropathy, a sensory neuropathy, and there are lots of causes of that, but PBC is not a typical cause of that.
Thank you. We've also got a question around changes in biochemistry. So is it possible or normal for ALP and ALT to peak, become much higher, then return to normal as before due to bacteria like, now my pronunciation might not be right here, but it's Cryptosporidium? Sporidium?
Yeah. It's possible. I think it's unlikely, but it is possible, yes.
Yeah, I think that there has been, we've been asked some questions before about can changes in your ALP be related to something else that's going on and
yes,
not necessarily always your
it's
liver.
not always PBC, and your doctor or physician should take that into account, really. And you might be monitored for a period of time to see where the ALP will settle down.
Mm-hmm.
The other factors can aggravate the ALP. The most commonest thing is that we see today is people who have a fatty liver because they're carrying weight, for example. That can sometimes impact and cause an elevated ALP or contribute to that.
That's great, thank you. Actually, the next question is about weight, actually. Is there any connection between PBC and weight gain or any related diagnosis that can cause severe problems with losing weight?
No, so I'll say no to both of those. It's just common for PBC to occur in middle-aged to older women, and that's the time of life most people tend to put on weight and struggle with weight much more.
Mm-hmm.
And we tend to become less active and metabolically less active, and the one impacts on the other, though. So carrying weight is not an ideal situation for someone with any underlying liver disease, including PBC, as it adds to the burden of liver disease. But the PBC itself doesn't impact on an individual's ability to lose weight.
Thank you. We have a patient who was diagnosed with PBC in December 2023 from biopsy, and at that point started Urso. The biopsy was stage 2. They were misdiagnosed in 2012 with AIH.
Mm-hmm.
The biopsy from that time was rechecked and showed PBC and not AIH. Mm-hmm. And at that point, the biopsy also showed stage 2 for PBC. They've lost weight, eaten healthier, but recent blood work shows high cholesterol. They believe that something else might be at play. What would your advice be? When they were 25 pounds heavier, their cholesterol was near normal.
Yeah, so that clearly should be looked at separately. I'm not sure how old this person is, but at a certain age, we become more prone to elevated lipids. Cholesterol is a lipid, fat, and that may kick in. I'm not sure of this individual's family history and whether there's a contribution from that, or whether they've now developed an issue with hyperlipidemia, but that should be addressed. PBC, by the way, does predispose you to hyperlipidemia, and that impact will often occur over many, many years. It's not something that's often obvious at diagnosis, but there's a higher prevalence of hyperlipidemia and PBC patients if you follow them over many years. So it may mean that this just many years is a factor. It may there may be other factors that are unrelated to the liver disease, and that certainly should be discussed with their physician. Yes.
That's great, thank you. We've got a patient who takes 600 milligrams of Urso per day for their PBC, and they've been doing that for approximately 7 years. The local pharmacy is now saying that they're having trouble procuring Urso at the moment. Are you aware of a shortage at the moment? I think it's something that's came up in our Q&A previously, and it's not something that we're aware is a major issue here in the UK at the moment, but I'd be interested to hear if you're aware.
It's not an issue in Australia, and I would really only know about Australia. And speaking to colleagues, I've just come back for only a few weeks. Mo was at the same meeting. She actually gave a very good talk at the meeting from a patient's perspective. Well done, Mo. And we were at the European liver meeting, which is a very big liver meeting, and PBC's taken a higher profile than it used to, just for people to know amongst the medical community who goes to these sort of conferences. I think Mo would probably agree with me. Compared to what it used to take, there's much more interest in it. There genuinely is much more interest.
I actually even heard it referred to as the PBC meeting this year because there was so much PBC inputs.
And there was a lot of stuff that we get involved off-site. So there's global PBC, there's a process looking at PBC and autoimmune hepatitis overlap happening. So these were separate groups that take advantage of the fact that most of the interested parties are there. But the question, just to remind me, I'm getting sidetracked.
Was about the shortage of Urso.
Yeah, I haven't heard anyone mention that, and you do bump into. So I don't know where this particular individual's from. I'm questioning whether it's a shortage of that dose in particular, because it's a little bit of an uncommon dose, 600 milligrams. So most of the availability comes in 250 milligram,
right?
Tablets / capsules really. So, but I haven't heard of that, and it's certainly not the case in Australia, where I'm from.
One thing that they've said that they've been referred back to their doctors, so they've got another appointment to follow up on it, but they're asking if there would be an alternative. So I think it would just be worthwhile mentioning the different doses that's available, just in case you could maybe get a different dose to make up her 600 milligrams, but to be if it was out with the normal dose that she would get.
So the 250 milligram is the usual dose, is the most frequently available. There's a 500 milligram dose made by the Urso brand, and I'm not sure of this individual's weight, but you might have to go up to 750 or down to 500, and it's a weight-based dosing of 30 milligrams per kilogram of body weight is the optimal dose. So there may be room to do that, or an opportunity to discuss that. There are alternative drugs. We sometimes use off-label drugs called fibrates, which are lipid-lowering drugs, and they have some role, usually not on their own, in combination with other medications, because we would see them as more complementary and not the primary medication. And there's now, in a lot of countries, the availability of obeticholic acid under various brand names, and that's not available in all countries, and I understand that, but in Australia, it's available, for example, as it is in a lot of countries, if you don't tolerate Urso, which is extremely unusual, or if you fail to respond to Urso adequately, and there's some guidelines that are different in each country.
That's great, thank you.
The new drugs that are not on the horizon in the not too distant future, but they'll probably have those same restrictions.
That's great, thanks very much. We've got a patient who was diagnosed with PBC over a year ago, and do they need to be concerned about a tick bite that they've got?
No, I would just treat that separately, and I don't think it's likely to aggravate the PBC. And if you get tick bite fever, which is the main consequence of the common tick bites, it's quite easy to treat with antibiotics, simple antibiotics, which shouldn't upset the liver because the course is very short. You can get other diseases from ticks that are more challenging, but I don't think this is the place to discuss other diseases, but it's not going to affect your PBC, so don't worry about that.
That's great, thank you. So our next question is, a patient who has suffered a stroke recently, does having PBC put them at higher risk?
Most likely not, no. It's probably just coincidental, and there are probably other risk factors that should be looked at.
Thank you. We've got a question about a negative AMA result, and there was also a late notice question came in that was similar. Just let me bring that one up. So 2 questions around that. Does a negative AMA result ever change? And then this other question was, when someone has AMA positive, can it change to negative? And if so, is it really still positive? So
I'll answer the first question. The second question is easier to answer. A
yeah.
lot of people, once they're on treatment, will become AMA negative. Not everyone, but a lot of people do. And that's just one of the benefits of treatment. And if you stop treatment, it'll become positive again. So you don't lose the disease. If that's what you're asking, you're not cured. If I go back to the first question, which I've never been asked that before, if you're AMA negative,
Can it ever become positive?
yes, it can actually. It doesn't, but it about 10% of people with PBC are AMA negative, and probably most of them will never become positive. But it's remotely possible, yes. It doesn't change what we do, though. If you have the disease, you have the disease, whether you're AMA positive or not. And sometimes just to elaborate a bit, there are other antibodies we use, which I'm not going to get too technical about, that some AMA patients have other antibodies that are pretty good at stating you have PBC and pretty accurate. And they need to be, if they're not available in all countries, but if you can get those other antibodies done, that extended screen done, antibody screen, it is important, because it's those people, not overwhelmingly, but a lot of them will do very poorly untreated. So they actually we need to have a higher level of concern about AMA negative patients who have other antibodies positive, and so you can just be AMA negative and have no other antibodies positive and still have PBC. There's a small number of people like that.
Okay. We have a question. We've got 2 questions actually around Urso. Does Urso reduce itching?
Probably not a lot. I think to me, I've always looked at it that it depends a lot on how early you treat those patients. So not a lot of patients have itch early on in their disease, but some people do. My experience is, if you can get the disease under control, those people benefit from an itch. But once the disease is very entrenched and has been around a long time, and there's already a bit of fibrosis, I don't think Urso probably benefit some small numbers of people in terms of pruritus, but you usually have to treat the itch separately. I don't think it's a brilliant drug for entrenched PBC itch.
If it's okay, I just wondered if we could cover just some of the other treatments that are tried for itch. Sort of anything else that patients might try, or options that might come up that would be I know there's nothing specifically for itch, but I know that there's treatments
some
that
people
are tried.
respond. I mentioned fibrates, a lipid lowering drug. It's quite good for a lot of people with itch in conjunction, say, with Urso. So a decent number of people will benefit from itch in that regard. We sometimes use an old-fashioned lipid lowering agent called Questran, or it goes under the name of cholestyramine, really. Questran's the main trade name. That actually has been in short supply on and off the last few years since the start of the COVID epidemic. So that's sometimes useful. We sometimes use an opiate blocking drug called naltrexone. Sometimes that's useful for an itch. I haven't, to be honest, I haven't found it overwhelmingly beneficial to my patients, but there's data on that. We use rifampicin, that's an antibiotic sometimes, to help itch. And people have tried obeticholic acid instead of Urso to help the itch, and it probably helps some people, but it can cause itch as well. So it's a bit of a conundrum that its main side effect is that it can cause itch. So it's not something you're going to get very excited about trying to help itch, but it paradoxically helps some people. So those would be the main medications we use for itch. There are other, some people will benefit from antihistamines, from various ointments to help ease the itch. I don't think they fix the itch, but they, in conjunction with the other medications I've discussed, they might provide some extra relief. And then there are basic things like heat is going to aggravate an itch, coolness may help an itch. So there's a lot of lifestyle measures that one could try that help some people.
Yeah, and I know our patients tell us that, and certainly it was the case for me, that the itch can be worse in the evenings when you're trying to sleep as well, so
Yeah.
can cause
So
sleep disturbance and that kind of thing.
distraction helps an itch. You can't focus on your itch if you're busy and you're occupied, and all itch, not just liver related itch, will be worse at night when people don't have the distraction.
That's great, thank you. And another question around Urso is, does Urso help hyperthyroidism since it brings down ALP, which also affects bones?
ALP doesn't affect bones. Bones have ALP in bones. It doesn't impact on hyperthyroidism at all. They separate illnesses, even though on an autoimmune, you can get an autoimmune type thyroid disorder much more commonly in patients with PBC and vice versa. It's probably part of the genetic spectrum, but treating Urso is very liver specific. There have been the odd publication where Urso's fixed up some other autoimmune phenomenon. No one, but that's really just the odd esoteric individual or case. We
That
had
was
a case
something.
many years ago, a patient with presented with autoimmune related hemolytic anemia to the hematologists, and then they found the liver tests were abnormal. They said, before we put the patient on steroids, because that's how you treat autoimmune hemolysis or breakdown of red blood cells, can you see a liver doctor? And it looked like PBC. We biopsied this patient, and it was clearly PBC, and we put her on Urso and sent her back to the hematology doctors, and beyond everyone's surprise, the Urso fixed the hemolytic anemia. No one knows. This case is actually published and discussed and been presented to hematology meetings, and no one's got a clue how it fixed the autoimmune hemolytic process. So I think we should see it as a PBC specific drug.
That was something that actually I learned at ESA was about ALP. I always thought ALP was something that was primarily in the liver, but there was talk of it of where else, and you mentioned there about the bones as well. So it's found in other parts of the body. Yeah.
It's predominantly comes from the liver, but there's a lot of ALP from the bones. Yeah.
And that's why maybe if someone might have a fracture or something, that the ALP could increase whilst they're
and in kids have a much higher ALP than adults, because growing bones release a lot of ALP into the blood normally. So a normal for a kid is very different to a normal for an adult. It's set at a much higher level.
That's great, thank you. I've got a question about a patient who has regularly swollen ankles and asking if that could be related to PBC.
It's possibly only related to PBC if the liver's reached a point where it's starting to fail. When the liver fails, you don't make enough of a protein called albumin. Albumin holds fluid in blood vessels. If you have a low albumin, fluid leaks out of blood vessels into soft tissues, and it's often gravity dependent, so the legs and the abdomen are very vulnerable to that. Otherwise, there's no relationship, no.
Also a question around body temperature regulation and if having PBC can cause issues with that, and if so, why?
I don't think that's well documented. I don't think that's a well-recognized phenomenon, but it's fascinating that you bring it up because I've had other patients tell me they feel their body temperature is dysregulated, but there's no, so we don't know if those people feel that their temperature is dysregulated or it really is dysregulated. It's not how they feel, or it's really dysregulated, but it doesn't play any role in temperature control per se, as far as we're aware.
And a question around stress. Does stress play a part in PBC, either with disease progression or symptom burden?
So I don't think stress plays any role in the initiation of the disease or disease progression in the liver. It definitely plays a role in disease burden. I think those of us who work in the field see that all the time, because when we stress, we perceive these symptoms in a much greater way, and we get anxious about those symptoms, which aggravates our stress. So to me, it's bi-directional. It's both ways, that the stress makes us perceive these symptoms much worse than if in our minds, or they seem worse, we worry more about them, and it's that ongoing cycle, which is really bi-directional. I think it aggravates stress as well.
And that's something that us at the foundation and other patient organisations can help with, as well as by patients reaching out to us, we can provide them with information and help them. And also our things like our self-management sessions that we do every week can be really, really good for things like that. I think just to talk to other patients can be good as well. Just to share that.
Yeah, so I really don't think we should dismiss how stress interacts with the way our patients feel. And it's not unique to this disease. We see this in a lot of other illnesses, chronic illnesses, we and other specialists manage. But and so it's well recognized. There's some studies on this, not in PBC, but in other diseases that show this ongoing relationship to stress and symptoms.
And I think the chronic part of it can be a worry for patients as well, not knowing potentially what the future might hold and worrying about that. Yeah.
No doubt.
Yeah. So that's all the questions that we've been sent in. I've got one more question that's been sent in that I haven't covered yet, but I wondered if we might be able to cover it in a wee bit more detail. We are a bit early for questions coming in live this morning, so there's nothing live at the moment. But we have got a question around some information on post-transplant and also recurrence of PBC. I wondered if that was something we could spend a wee bit time covering in a bit more detail.
I'll do my best. Sorry, excuse me. So, excuse me. I don't personally work in a transplant team, so I'm not a liver transplant doctor, but all autoimmune liver diseases will come back after transplant, and PBC will return after transplant. And like other autoimmune liver diseases, it needs to be treated. Autoimmune hepatitis is a related illness, is a bit different because the anti-rejection drugs will probably deal with that a lot better than the anti-rejection drugs don't really help PBC in a large way. So you would at some point need to go back on PBC treatment. We know for most people, PBC takes a long time to cause serious liver disease and to damage that transplant long enough. Otherwise, they wouldn't do a transplant. So if you were going to have PBC come back in a year in a very destructive way, there'd be no point to using that liver to save someone's life when a lot of other people might get 30 or 40 years out of a liver. So because PBC is a very slowly evolving disease, Now that might be altered by the autoimmune drugs that you get given to prevent rejection, and those are little nuances that are probably, that are hard to go into. It's really challenging to really understand. But if you had a transplant for PBC, you are likely to go back on PBC treatment at some point, and that should be well managed, because you want to preserve that liver for a long time, and you have that window of opportunity, knowing that this disease is going to come back, so you will treat it.
And would
And
that treatment be going back on Urso after transplant?
yeah.
Yeah.
And if you need something else, like we've mentioned already, so be it. And I think, to me, that would be the great opportunity. Otherwise, you wouldn't transplant. Really, if you knew the disease was going to come back aggressively, you just wouldn't transplant PBC patients. So obviously, there'd be the motivation to look after these people who've had transplants for PBC. The transplant team and your other caring physicians and liver physician would be very, very keen on looking after someone like that. A lot of effort's gone into that individual, and it's not a big deal to put them on Urso.
Yeah, and you're routinely checked often after transplant anyway, so
To
anything
be
that
very aware of that, yeah.
was going to change, it would be picked up quite quickly.
Does that adequately answer your question, Mo?
Yeah, I think so. It was just to get more of an understanding of recurrent PBC, and just when we were mentioning earlier about the positive AMA, when you're post-transplant, do you remain positive AMA? Does that
Well,
change after transplant?
that's a hard question. I think it can, but it doesn't have to. No,
Right,
you can
so
still have an AMA.
still be the same. Yeah, because PBC is not necessarily active just straight after transplant, but there will
Correct.
be,
Correct.
it could be over time or could be
It could
never,
be
but
over
it could be over.
time, yeah, and
Yeah.
it could take a long time to come back. But you're having so many blood tests so often that the awareness will be there. And you, as an individual, when you're very engaged in a transplant, you're going to want to know every single time you go for a blood test what your results are. And that ALP will always ring a bell.
Yeah.
So you'll be asking that if your physician, by your transplant physician, perchance forgets, which I don't think they would, but if they did or overlooked that, you'd be onto it very quickly. You haven't
I
gone
think
to a transplant for nothing.
that's really important for patients, isn't it, to be aware
Yeah.
of the results and what they mean. And that's something else that we can help with. I know that if patients are a bit stressed about going to medical appointments or need a hand to prepare for that, we can help patients with that as well, just so that they
Yeah, and I think
know what
everyone's
questions to
different
ask.
how much information they want to know, but
That's right.
I think I would hope most physicians these days would be forthcoming with giving over results and letting you have what you want reasonably. That's not going to take them hours on end to prepare for that. That most physicians wouldn't have that time if there's a ridiculous requirement. But showing someone a result or giving them a result, copy of a result's not a big deal. And some people want that, others don't want that. Okay, you've told me what I need to know. That's all I want to know. That's enough for me. So we all are satisfied in different ways. But it's, if you're reasonable about it and you don't have unreasonable expectations of your physician, I think most physicians would say, yeah, by all means, come and look at the computer or have a copy of the result if they can print a copy for you or email you a copy. I don't think most physicians would not want to do that.
And that's
Is
something
that
that
your experience,
yeah,
Mo? And
certainly. That's something. And some patients can access their results through an app from their health board.
okay.
Some patients can ask for. Certainly, I used to ask for prints before I had my transplant. It was quite some time ago now, so it was printouts at that point. But we can ask for information
Yeah,
via
I get
email
patients
or
who
anything
ask
like
me to
that.
print the results or email it to them, or others who they don't want to have the results. They just want to know it's good, and that's fine too. So we're all
And you're right.
different,
Yeah,
and
patients
the
will ask for
way,
different levels.
but having that knowledge, I don't think doctors want to not provide you with information or knowledge, these days, certainly in the specialist world.
And I think it's if you are asking for your results, it's understanding what they mean as well. So if you need a
absolutely.
wee bit more explanation, feel free to ask your doctor to
Yeah,
explain
and
it in a bit
sometimes
more
just
detail
taking the
for you.
results home and thinking about them and discussing, maybe I should have asked my doctor this. Just go back at your next, just make a note. I just tell people,
Mhm.
we've all got mobile phones these days. Just put it in the notes and go back there with your list. It's easier for us actually if we know what you want to know. For me as a physician, just it's easier if you're gonna not walk out of my office and I should have asked the doctor that. Just come with your few questions, even if it's one question. Okay, that we can cut to the chase and deal with that very easily.
Yeah, that's something I know personally I did as well, is that, and it was on the notes on my phone. If anything came to mind I wanted to ask, I just took a note of it. And then the next time I went into clinic,
Yeah,
I
it
had my
makes
list of questions to
it
ask.
honestly makes my life easier because I know I'm answering what someone wants to really know.
And I think sometimes you prepare for your appointment mentally and then you go in and you forget things that you
Yeah,
might wanted to have asked.
yeah.
So
I think
just
that
doing that wee
really,
bit
really happens. Yeah,
prep ahead of time, just so that you've got it written down. Because sometimes it depends how often you're being seen as well. It might be another 6 months before you get a chance to see your doctor. So it's important that we all make the most of that time when we've
yeah,
got it. So
yeah.
um,
And you can. It makes it easier for the doctor actually, because you just cut to the chase.
yeah, and take in the information that you were looking to get.
Mm.
That's, as I was saying, that's all the questions we've been sent in for today, and there isn't anything new coming in. But I just wanted to touch on EASL again, because just what we were talking there about chatting with your clinician, one of the sort of recurring themes in some of the PBC sessions at EASL was around asking doctors to speak to the patients about their symptoms and quality of life as well. And I saw that as a real theme to look beyond the biochemistry and
Yeah,
ask patients how their symptoms are day to day. And I think it's
yeah.
important for patients to know that that is something that they should be mentioning to their clinicians at their appointments as well.
I agree. I mean, it's valuable to not. You don't have to be brave or put on a stern face. If you have symptoms, you can ask your doctor, are these symptoms from PBC or not?
Mm-hmm.
And I think a lot of doctors haven't voluntarily asked the most common questions like about itch and fatigue. And not everyone gets itch and fatigue. So some people say, no idea what you're talking about, but I'm fine. And that's good too. Good for the doctor to know that too. So I think my uh, my profession's under asked those questions historically, and partly I think a lot of people have seen doctors who just have one or two patients historically with PBC, so they haven't had that experience.
Mm-hmm.
All doctors have got too used to that individual, in a sense that they know that they've just become too comfortable, and they sometimes forget to ask those questions. So you can volunteer about how you feel. You can ask if your symptoms are related, and as long as you make reasonable use of your time and you don't give them a 20-page essay, I think most doctors would be happy to deal with that. And I think there's been a lot of, it's almost like lobbying, wouldn't you say, Mo? There's posters around the conference. Have you asked your PBC patient if they got an itch? And it's driven in part, it's a good thing, but it's driven in part because drug companies are coming into this space,
Mm-hmm.
and they have to be able to engage doctors or they're never going to want to learn about their drugs. So doctors don't, in days gone by, you know, there were a lot of things that doctors got that might have been more useful to them, and doctors just want information now. They're like everyone else. They just want good information and want to be contemporary and up to date. I think most doctors are like that when they go to a conference. So it's an opportune. So drug companies will use these posters to with their brand name on it, but
Mm-hmm.
they're doing a lot of good out of that because they're highlighting to doctors, there's treatments around for these diseases. You need to ask about these diseases, and that's we're going to work in this space. So that's our contribution, as a
Mm-hmm.
pharmaceutical company. It's our goodwill contribution is to highlight all of these issues. A lot of pharmaceutical companies are learning about PBC as well. It's not a common disease, and
Mm-hmm.
it's never going to make them tons of money, a lot of money, or so. But some people make a buck out of it, and so they have to be able to engage with patient groups, with the medicos in a reasonable way. And there was a lot of posters around and a lot of talk about that, wasn't there, at the last conference?
Mm-hmm. And I think another thing we were chatting there about patients taking their questions in for the doctor. I think if they are experiencing symptoms regularly, I think it's good to record them as well, because it might be on the day you go into clinic, actually your itch isn't too bad, but it's been really bad over the past few months. So I think just keeping track of that can be really useful as well. A lot of patients use our app for that, so on a daily basis they can just track how they're feeling, and then you can go back and look at the graph and see how your symptoms have been, which I think can be useful when you're having a chat with your doctor as well, so they know how it's affected you over the last few months. Yeah. I'm just going to, I did want to cover EASL today, so it's been nice that we've had time to do that, but I've had a question pop in live, so I was just going to go back to that just now.
Yeah, no, with a pleasure.
And then we can come back to EASL if we've got some spare time. So we've got a patient asking, is it true that since I was diagnosed with lung cancer back in March and had the lobe removed, and now if my liver needs a transplant, I won't be able to get one since I've had cancer?
It's going to be different in different countries. I'm going to tell you that. It does make it very, very hard if you've had a pre-existing cancer, and they would have to be reassured the likelihood is that cancer's cured. So they would look at a period of time, and I'm not an expert at lung cancer, so I'm not going to be dogmatic about the time, but in general, it's looked at as 5 years in the oncology world. So if you're in remission for 5 years, for most cancers, you're probably cured. Now, that's a sweeping statement, and I'm no expert. It doesn't apply to breast cancer, for example, and to one or two other cancers, but I think that does apply to lung cancer. So that's probably the timeline they would look at that.
I'd just like to say to that patient, I appreciate that's a lot that you've been dealing with just now, and if we can be of any more help, please give us a call on the helpline and we can have a wee chat with you and see if there's any more detailed information that we might be able to get you more information on as well. So please reach out to us if you'd like to talk about that. We have another question coming in live.
Great.
Patient sometimes gets a pain under the ribs where the liver is. It's a few hours here and there, more uncomfortable than needing painkillers. They forgot to tell their consultant at their last appointment. Is it a problem or normal for PBC? Their recent bloods are normal and they're on Urso and bezafibrate and gabapentin for peripheral neuropathy.
So I think what you're talking about is right upper quadrant pain in the right upper part of your abdomen, just under the ribs, where the liver sits, the gallbladder sits, and a little bit of the bowel sits as well. And their muscles and nerve endings there. So the pain could be for lots of reasons. Most pain's musculoskeletal in that area, so the muscles or the skeleton. But people with liver disease get pain in the liver sometimes, and it's very non-specific. It varies from individual to individual quite wildly. The fact that your liver tests and the fact that the liver tests in this scenario are so good make it less likely it's liver related, but it could be. And these pains are very hard to interpret. We see more pain in diseases where the liver swells, for example, like say fatty liver disease, where the liver's engorged with fat, the liver stretches and swells, and people get pain. And there's no specific pattern of the pain, unlike there are for if you broke a bone or something like that. The pain can vary from individual to individual. So it may be related, but it still could be musculoskeletal. That's the most common source of pain in that area.
Okay, thank you. I'll keep an eye for anything else coming in, but just going back to EASL, what was your highlight of the conference?
So I don't know if I had a specific highlight. I like going to see the posters, because the stuff doesn't get as high profile as the main presentations, and people do awesome work, awesome research, and the best posters to go and see are either the awarded posters. So some posters get awarded, it's sort of like a medal. So if it's in my field, there's stuff that's quite different to the type of work I do. I may not be that interested in, but I'll go and look at those posters. And I think it's on the second day you get the late breaking posters. So these are people who submitted an abstract very late. They're often drug trials or something quite novel. So they want it out there very urgently. They don't want to wait for the next liver conference. So it's quite good to go and see that get that sort of information, and it's sometimes surprisingly quite novel, and you can see where various liver illnesses are going. What's new and what people are working on. So to me, I always make an effort to do that. I'm going to give the symposium Mo spoke on. So people may not know, at most conferences, the pharmaceutical companies who are sponsors of various things, and the only way they're legally allowed to get to medicos or medicos are interested in engaging them is if they put on a symposium. So they will get some experts and have a symposium, obviously in the field they work in, with whatever drug they do, if it's for hepatitis C or if it's for liver cancer or if it's for PBC or cholestatic liver diseases or a genetic disorder. They'll sponsor a symposium. They'll have an expert committee of doctors set up that symposium, and they'll invite appropriate speakers for the theme of that meeting. And they tend to occur at the end of the day or at lunchtime, and it's optional for people to attend. So the content has to be really good because doctors are at these conferences, and doctors and scientists, and they are overloaded with information. And they've got very good at translating information that's useful to doctors to use in their day-to-day work. And the PBC meeting, or the cholestatic meeting that Mo spoke on amongst some very good medical speakers, was packed. It was so packed that they had to deny entrance to people who couldn't get in because there were too many people. So it just shows you how much interest is developing into PBC and other cholestatic disorders and autoimmune liver disease. That 10 years ago, that room you wouldn't have been able to put that on because you just wouldn't have had enough interested parties walking in to listen to that. So it was packed. It was very well run. The speakers were all excellent, including Mo. One of my colleagues that I work with in my department, who's just what I would call a general gastroenterologist who does a bit of liver disease, came to his first ever liver conference, and he said this was the best conference he's ever attended to from a knowledge perspective and an organizational perspective. And he went to this particular seminar, and he was telling everyone about it afterwards, what a good seminar it is, how many insights it's helped him, how he's understood things differently from a patient's perspective, listening to Mo, and how he should think differently listening to some of the other speakers. So it's a bit of a plug, but these sort of things it's just to show how much interest I'm highlighting, to show how much interest there is in this type of disorder. In Asia, when they put on the first PBC/autoimmune liver disease seminar at the Asia Pacific meeting, which was about 8 or 9 years ago, I got an email saying, I know you're a speaker on the symposium. Don't be shocked if there's only 40 or 50 people. And there's 2,000 people, 3,000 people in the next room listening to hepatitis B. Just accept it. We've got to start from somewhere. And that's exactly what happened. I was blown away how few people there were and how many there were in the other room. But things do change, and they'll change in Asia as well. At some point, there'll be a tipping point, but certainly in Europe, cholestasis has taken on a much greater profile. And I would venture to say probably North America as well.
there was a couple of, because there was so much PBC activity at the meeting, we were splitting up to go, Robert and I were splitting up to go to different ones so that we could be sort of everywhere and hear what was going on. But there were some sessions that I turned up for, I meet the experts in particular that I turned up for, and it was full and I didn't get in either. So I think it just shows the level of interest.
So it just shows the interest amongst the medical and scientific fraternity. And I think it's predominantly medicos that a lot of people are now motivated to do better. In part it's driven, this is how it works, it's driven by new drugs being available, like obeticholic acid and maybe new drugs on the rise, and people feel motivated doctors feel a knowledge gap if they haven't worked a lot in that area, like say a doctor like me or one of the other doctors who do these Q&As. So they feel they're missing information, and it's really good that they're motivated to go and learn about that.
And as a patient, it was a real privilege to be able to speak direct to doctors in that way as well and bring the patient experience to that.
And a packed audience. And did you find it a receptive audience, Mo?
Very much, yeah. And actually, as the next couple of days after I'd done my talk, there was quite a few doctors came up and spoke to me about it, which I thought was really good as well. People had then came over to our booth and reached out to us as well, which was really good too.
Yeah, it's definitely a change. That's like not how you couldn't have run that seminar if you had that 10 years ago. You might have been lucky to have 15, 20 people, and they would have mostly been doctors you knew already, who didn't need to be educated.
And this year at EASL, so there's the big exhibition hall that has all the industry partners in it. They have their booths there. But what EASL did for us this year was there was 5 patient organisations there, and they put us on the main part just outside the main room, the gold room.
The high street, huh?
Yeah,
main traffic area.
Yeah, and that's the first time they had done that.
Yeah,
but because it was
I was amazed they did that actually.
Yeah, and because it was the 5 of us together, it meant that if people were coming to look at one of the patient organising booths, they were chatting with us all. So it was really good. We got a lot of footfall just because of where we were. And I think us being together and us being in such a high profile spot was excellent. So that was a really good position to be in for people coming by, and people were seeking us out and coming to get information after they'd been at other PBC sessions as well, which was good to see. And we made loads of contacts and met lots of lovely people as well, it's a real opportunity for us. We had 3 of us there this year because there was so much PBC activity that Robert and I were going to as many sessions as we could, and then Linda came out to join us as well, and she was on the booth for us, which was great. So it meant that because the booth was getting so much passing traffic, we wanted to have someone there most of the time as well. So we made sure that was covered. So it was an
Linda
excellent
worked
meeting.
very hard.
She did. It was an excellent meeting this year, and so good to see PBC at the fore getting discussed at that kind of level, which is great.
Yes. So I don't know if there are any other questions.
I'm just doing one last check, but I think that might be us getting ready to wrap up.
That's all right. I can go back to my clinic then.
I might go back and put my pajamas on, seeing it's only, it's 5 to 6. I suppose I really should stay up now. I should stay up now. But yeah, thank you so much for joining us.
Thank you all.
Thanks for the questions. We have covered all the questions today, but any more questions, please just send them in to us at info@pbcfoundation.org.uk. And also remember that we upload all of our Q&As onto our YouTube channel as well, so you can watch them on replay on there as well. And anything else, please just reach out to us. We're here for you. Please just reach out to us.
Yeah, I'd just endorse what Mo says.
Thank you. Thanks, Martin. Have a good day. See you later.
Bye.
Take care. Bye.